So, dear all, thank you for joining us in this interview today. I'm Jean Célément, a vascular surgeon in Henri Mondor University Hospital in Créteil and a member of the social media team of the PVI Congress held in Paris. I'm happy to present to you the Dr. Fausto Castriota, who will be a faculty member of the Paris Vascular Insight course next December. Dr. Castriota, could you please introduce yourself for those who do not already know you?
Hello to everyone. My name is Fausto Castriota. I'm an interventional cardiologist, but also radiologist, involved since many years in the treatment of cardiovascular disease, starting from carotid, coronaries, BTK. So I'm happy to join this very nice congress. I'm working in Italy. I'm the director of the interventional cath lab in the GVM group. Our clinic is Maria Cecilia Hospital in Cotignola, close to Ravenna and Bologna.
Thank you for this introduction. Dr. Castriota, in your opinion, what are the indications and developments in both CAS and open surgery, and how are they distributed between the two techniques?
That's a nice question. In terms of indication, fortunately, we have guidelines that are explaining very well that we have two different words in the carotid disease, means a symptomatic patient and asymptomatic patient. In these two words, we have clear indication on the type of treatment. In any case, we have to treat the carotid stenosis in a symptomatic patient where this more than 50% with symptoms and more than 75-80 in a asymptomatic group. In terms of which kind of procedure, of course, also following the guidelines, we know that in symptomatic patients, probably surgery is still the gold standard. But in any case, in all population with carotid disease, we must be very honest and frank to say that it really depends on the expertise of every single center. Because the percentage of the results are probably the most important point. What I mean? I mean that we must be sure that our rate of complication is below 6% in a symptomatic patient and below 3% in asymptomatic. It's the clue. If the center is very focused on carotid stenting, why not? If the center is really focused on open surgery that works very well, why not? So it really depends.
Thank you for your answer. And what technical advances have been made in specific devices designed to prevent strokes?
As you know very well, we start performing carotid stenting in the 90s without cerebral protection, and the rate, not to be honest, not the major stroke, because we are very selective in the choice of the type of plaque. But with the protection device, of course, we are able to reduce the percentage also of minor strokes pretty below the 3%. And of course, we have different type of cerebral protection devices. In my opinion, now the proximal protection device probably is the best system, because it allows us to protect the carotid even before crossing the lesion with any kind of wire. It's quite difficult to have a stroke using an 014 wire, but in some type of plaque, to have a proximal protection device is very good. In any case, also filters are working very well and allows us also to perform procedure using the radial approach. So, like always, we have to tailor the use of your protection device following anatomies and type of lesions.
And Dr. Castriota, what are the developments in terms of stents and procedures to prevent stroke and restenosis?
Yeah, also in terms of stents, the technical improvement was huge, and because all the data we have collected in the past, and also data used to write also the not also the study, but also I was mentioning the guidelines are with the old generation of stents. The new generation of stents, I'm talking about the double layer stents, allows us to work in a very easy manner because are very flexible stents, and the percentage of covering of the plaque is amazing. We start with the use also of the OCT, like in the coronary, in the carotid stent. In our initial experience, using a double layer stent, and protrusion of plaque is something very, very rare. So the evolution of stents put us in a way also to treat complex plaque, means with ulceration, means with fragile cap, means soft plaque, all type of plaque that in the past were straight to surgery.
And finally, Dr. Castrota, are operative indications adapted with plaque evaluation?
Yeah, I just mentioned that probably to know which kind of lesion we're going to treat is one of the most important points to perform any type of procedure, especially for carotid stenting. And in the real past, the soft plaque in symptomatic patient was a contraindication for stent. Now, with the new technologies, means proximal protection and double layer stents, probably we are also able to treat any kind of lesion with a very low risk of distal embolization. In any case, TIAs, recurrent TIAs, is very unstable plaque, and soft plaque, in my opinion, remain a perfect indication for surgery. Even with the new technologies, that kind of patient for me is like an acute, not carotid or carotid, it means carotid syndrome, but it's like in the carotid. Acute carotid syndrome and acute carotid syndrome have almost the same thing. And that setting of patient, I think surgery is much better.
Thank you very much, Dr. Castrota. Thank you all for watching us. We're looking forward to welcoming you in the next PVI course next December in this unique platform to stay up to date in various topics, to share your experience, and to meet worldwide experts. See you in Paris.